Get shorter.
Yeah.
Yeah, feel free to start.
Go ahead and start. So,
Yeah, Dr. Yasmin will be starting now.
Good evening, everyone. On behalf of the UAE National Multiple Sclerosis Society and IVPN, it's a pleasure to welcome you to tonight's webinar. I'm Yasmin Metwalli, and I lead the Research and Advocacy Department at the National MS Society. Before we begin, I'd like to briefly introduce the National MS Society, which is a UAE-based NGO created to better the lives of people with MS. Our vision is that no one continues to suffer from multiple sclerosis, and we do that through three key pillars, which are providing
Dr.
support.
Yasmin, can you share the slides again?
Oh. A second. Is my screen not showing? Hold on, sorry, let me just. Okay, can you confirm that you can see my slides?
Yes, just go full screen.
Okay. Is it clear? Okay. So the National MS Society.
It's not full screen yet. Yes.
Oh, it's not? What is it looking like?
You
Okay.
can see the slide, but not full screen.
I think you need to share the PowerPoint presentation, Yasmin, not your screen itself.
Just a second. Okay, this is what I'm doing. Is it showing in full screen?
No, not yet.
No.
Okay.
You have to see it full on your screen so we can see it.
The bottom right.
Can
Do you want me to share it on your behalf?
maybe you can share it? Yeah, let's do that.
Just tell me next and I can.
Okay. Okay, can we go to the introduction slide? Next, 2 slides. Okay. So yeah, I'll just start over here. So the National MS Society is a UAE-based NGO created to better the lives of people living with MS. And we do that, our vision is that no one continues to suffer from multiple sclerosis. We do that through 3 key pillars, which are providing support and resources for people with MS, raising awareness and reducing stigma and stigma associated with MS, and finally, through driving MS research to advancing our understanding of MS and advancing MS treatments. Next, please. Our work is guided by a medical advisory committee made up of leading MS neurologists and specialists across the UAE. They provide us with expert opinion and technical input that inform many of our projects and our strategic planning, many of them who are with us today as speakers, and we're grateful for their support. Next. And under our three main pillars, the National MS Society has launched several impactful programs and initiatives to better the lives of people living with MS. And over the past 2 years, we've launched several of these initiatives, of that being the MS Helpline. The MS Helpline is our direct support line for people living with MS and their families, where they can have their questions answered and concerns answered by trained professionals. We've also host several MS talks throughout the year, and we have a growing library of digital resources which focus on empowering people with MS with day-to-day topics such as nutrition, speaking to your children about MS, and navigating the workplace. As part of our research pillar, we also have a research grant cycle, which we have launched, which is dedicated to fund innovative MS research that aligns with our MS priorities. And we've just launched our third research cycle this year. We've funded over 11 studies over the past 2 years, and for this third cycle, the deadline to apply is the 24th of August. So we encourage everyone who's interested in MS research to check it and apply. We also have a dedicated research fellowship, MS fellowship, in collaboration and partnership with Minactrums, which is targeted for early career MS researchers. Another program that we've recently launched is the MS National Coalition, which is a cross-sector alliance dedicated to strengthen the national support program for MS across the UAE. For all of these projects, we encourage you to, that was the next thing. And then finally, a major milestone for the society has been the launching of the MS treatment guidelines, which is the focus of our webinar today. Next, and these guidelines have been born out of a clear need, which was the absence of unified evidence-based framework for MS. Next. Our aim, the aim for the society when they launched the guidelines was to advance equitable access to MS treatments in the UAE. The guidelines serve as an evidence-based policy tool which supports clinicians in decision-making and informs payers as well as policymakers on best practices in MS management. We're proud to share that these guidelines are officially adopted by the Dubai Health Authority as well as Department of Health, which marks a very important step forward in standardizing and strengthening MS care. With that being said, I'd like to hand over to Professor Jihad Inchasi. Professor Jihad Inchasi is a consultant neurologist at Rashid Hospital, Dubai Health Authority, and a professor of neurology at Dubai Medical College. He developed and currently directs the multiple sclerosis and dystonia clinics at Rashid Hospital. Professor Inchasi is a member of several local, regional, and international associations. He's a member of the Medical Advisory Committee of the UAE National MS Society, as well as Minactrums, Emirates Neurology Society, and others. Please join me in welcoming Professor Inchasi.
Thank you, Dr. Yasmin, for the kind introduction, and thanks for the society for the invitation. So, dear colleagues, friends, Assalamu alaikum. Good evening, everyone. It gives me a great pleasure to welcome you and thank you for joining us tonight for this interesting educational webinar, Navigating the Horizons, an update on multiple sclerosis treatment guidelines for the neurologists. This webinar is sponsored by the National MS Society, organized by the IVPN, endorsed by the Consortium of MS Centers, and accredited by Ministry of Health and Prevention. Big thanks for all for their contributions. Can we see the agenda? Okay, this is an interactive webinar. So we encourage all the participants, now I see more than 580, to submit their questions in the Q&A button or question, you see it at the bottom of the screen, and the speakers will be more than happy to respond to you. You can specify whom you want to answer your questions. And this is CMA accredited by the Ministry of Health and Medical Education and Preventive Medicine, and the organizer will notify you how to get your certificate. So this is the agenda. Dr. Ahmed Shatila will give his opening remarks, and then Professor Basim Yamout will give a talk on new diagnostic strategies for early MS detection. And this Dr. Ahmed Shatila will speak about disease-modifying therapies for MS, an era of abundant choices. And the last presentation will be given by Dr. Anu Jacob, International Standards to UAA National Guidelines in MS treatments. So now it's my pleasure to welcome and introduce our first speaker, Dr. Ahmed Shatila. So Dr. Ahmed Shatila will give his opening remark. Dr. Ahmed is a senior consultant neurologist and head of the MS clinic at Sheikh Shakhbout Medical City in Abu Dhabi. He's over 15 years experience in practicing and treating, managing different fields of neurology. He is double board certified from He is American board certified in neurology and neurophysiology from Wayne University in the United States. And he is the chair of the Medical Advisory Committee of the National MS Society. He authored many papers. The last one came last week on guidelines of myasthenia gravis, and he is a member in many prestigious organizations and societies. So we are happy to listen to you, Dr. Ahmed. The mic is yours.
Dr. Jihad, thank you very much for the kind introduction, and welcome everyone. First of all, assalamu alaikum. It's a great pleasure and honor to be here today. I've been working with IVPN for many years, and to see the collaboration of IVPN with the National Multiple Sclerosis Society to spread awareness and updates on multiple sclerosis to different healthcare providers is always a plus. I'd like to thank all the audience and the speakers for joining, and it's a pleasure. So we're going to talk today about the updates in the multiple sclerosis treatment guidelines for neurologists. So if we really go back, the multiple sclerosis treatment guidelines were published in 2024 in the MSARD journal, which is the Multiple Sclerosis and Related Disease Journal. But if we really want to go back, the idea of guidelines started in 2023. That's when the medical committee, I am a chairman of the committee, but this is not a one-person job. This was really the entire committee, and a special thanks to Dr. Anu and Dr. Basim. Without their efforts and their support, these guidelines could have never made it to fruition. So why do we need guidelines? First of all, guidelines help neurologists and different healthcare providers treat people with MS. It gives them a roadmap. If we look, we've got the Europeans, the Americans, the MENACTRIMS. There are different guidelines, and while they're very similar, they can be very different and very confusing. And then when you go to healthcare providers or payers, it gets even more confusing, because then which one do they follow? So by having national guidelines, this basically unifies one treatment pathway for patients in the UAE. So once the guidelines were formed, and this was not just a national multiple sclerosis society initiative, it was formed by 6 members on the Medical Advisory Committee, as well as the other healthcare providers and advocates in the community, where we spent over a year going over the guidelines. What's important? What should we include? What should we take out? How can it be practical? And then after that, what did we do? We sent it out to the public. 14 different neurologists in our community, again, got to vote on these guidelines and give us their opinion. So this isn't a national MS Society guidelines. This is everyone's guidelines. Every neurologist, I don't want to say every, more than 20 neurologists in the UAE from different emirates, different sectors, whether private, semi-government, or in clinic, had a say on these guidelines. So we all made it, we own it, it's ours. So after the guidelines were made, guidelines are just recommendations, right? They're nice, they help people, they provide roadmaps, but they can, if they're not adopted by a regulatory authority, they have no teeth. So how do you give these recommendations power? That's when the National MS Society, thank you for them, reached out to the DHA, the Dubai Health Authority, and it became implemented into the IJADA guidelines. And that's where you can find now these guidelines, part of the IJADA guidelines for the DHA. After that, we said, well, that's great. Dubai has now guidelines to help MS. But what about Abu Dhabi, the largest emirates in the UAE? Again, we reached out to the DOH, and we had experience now. We had already done the guidelines. We've already been through the DHA. So as a society and as a committee, we got better. So we were able to hash out the details, get the guidelines published, part of the DOH, within a couple months. So it went from a year to get the guidelines published to now a couple months to get them initiated in the the Department of Health. And that's why right now, if you go to the DOH and you type MS guidelines, you will see it. Now, who's it for? It's for all healthcare providers who manage and treat MS. But more importantly, it's for all insurance companies, all payers in Abu Dhabi who have people with MS. So now you have a government-approved document that you can use for your insurance, for your patients to help manage them better. Now, what's one of the best part of these guidelines? They're very patient-centric. You're going to notice, as different people will talk today, it focuses on the patients. And what do I mean by the patients? We do have different classifications: moderately active, highly active, and rapidly evolving. But what you're going to notice, all of the medications could potentially be given as first line, with the exception of alemtuzumab and hematopoietic stem cell therapy. So then how do you pick and choose? You pick based on what your patient wants, what would make their lives better, and what's good for them. It puts the power between the patient and the physician. And that's why these guidelines are so important. And that's why making or educating our colleagues and spreading it around the community is only the first step. So that is why this is just hopefully the first of many lectures where we do raise awareness about these treatment guidelines, because hopefully it will make a change on how we treat people with MS in the United Arab Emirates. And with that, thank you very much. I think I did my 5 minutes, Dr. Jihad.
Yeah, you took 7 minutes. Thank you, Dr. Ahmed,
Ouch, man.
for this brief. Okay, it's excellent briefing. So thank you very much. So we move to our first speaker. I'm delighted to welcome and introduce Professor Bassem Yamout, who will be talking about new diagnostic strategies for early MS detection. We know all Professor Bassem Yamout. He's director of the Neurology Institute at Harley Street Medical Center in Abu Dhabi, and he's the president of the MENAC terms. He is a professor in neurology at the American University of Beirut Medical Center. He received his training in neurology at the University of Cincinnati, Ohio, followed by fellowship in immunology and MS in Montreal, McGill University. Professor Yamout is a fellow of the American Academy of Neurology and a member of the MSIF International Scientific Advisory Board, and he is a member of multiple regional international MS advisory boards. Professor Yamout is a leading expert in multiple sclerosis in the Middle East, with a recent research epidemiology, quality of life in patients in the Middle East, treatment, novel therapies such as stem cell therapy and venous thrombosis, venous stenosis, and the impact of wars in MS. In addition, he is currently a principal investigator in several ongoing international MS trials. Finally, Dr. Yamout has authored many research review papers and chief editor of MS newsletter, the MS today, and he is on editorial board of multiple sclerosis and related disorders and pediatric neurology. Again, Professor Yamut will talk about new diagnostic strategies for early MS detection. Please, Professor Yamut, the stage is yours.
Thank you very much, Jihad, for this kind introduction. I will try to share my screen. Can you see it?
Yes, Dr. Yamut.
Very good.
Yeah, we see it.
Thank you very much for the NMSS and for IVPN for putting together this symposium, which I'll kick off by discussing the new 2024 McDonald criteria in MS diagnosis. These are my disclosures. As you know, we've been diagnosing MS based on the McDonald criteria since the year 2000. And these have the basis of all diagnoses. If you look at the latest version of the McDonald criteria, they were back in 2017. And if we compare them to the previous one, we had a significant improvement in their sensitivity and even their specificity. If you look here at the 61% specificity, actually, when we went back and looked at the trials with the patient that did not receive a DMT before the end of the follow-up, the specificity was actually up to 90%. So with a 70% sensitivity, 90% specificity, we were doing very well. Yet, we still have a lot of misdiagnosis. And this is one of our own studies that we did between Lebanon and Kuwait in two major MS center referral. We looked at 431 patients that were referred for diagnostic confirmation of the disease. And sure enough, if you can look here, only 70% of them turn out to have MS, with 30% having other diagnoses. And if you look at these misdiagnoses, the most common ones were the non-specific, what I call benign mimickers. Like, for example, 16% had psychogenic symptom, dizziness, numbness, and so on. 14% or 15% had non-specific MRI white matter lesions. Almost 9% had migraine, and we know that migraine shows multiple white matter lesions. So we still had a lot of way to go to improve our diagnostic criteria in a way to avoid all these misdiagnoses. So if we look at the 2017 McDonald diagnostic criteria, we still had a lot of questions unanswered. How about RIS, radiologically isolated syndrome? Patient presenting with a typical MRI picture of MS and yet still did not have any symptom. Is it part of MS? Do we still need to document dissemination in time? You mean new lesions on MRI or GAD-enhancing lesion, or can we make MS diagnosis from the beginning, from the first presentation? How about the optic nerve? It was not included as one of the typical topographies of MS in 2017. Should it be added? Do we have any new biomarker for MS? And of course we do. There are many new biomarkers that appeared after the 2017 McDonald criteria, like the kappa-free light chain in the CSF, like the central vein sign on MRI, like the paramagnetic lesions on MRI, and all of these have to be added to the new diagnostic criteria. And finally, all of these misdiagnoses in elderly people and people with comorbidities, with migraine, with non-specific white matter lesion, we had to really adjust our diagnostic criteria in a way to increase their specificity to avoid such misdiagnoses. So ultimately, the International McDonald Diagnostic Criteria, we met in Barcelona by December 2023, and after a full 2 days of voting, we finalized the new diagnostic criteria, which should be published probably within the next 2 months. We've submitted them to the Lancet Neurology, and we're waiting for the reviewer's answer. What's most important about these new diagnostic criteria is that now we're having a new concept of MS. We are viewing now MS as a biological disease. You don't have to have symptoms to have MS. It's like Alzheimer. If a patient presents with possible memory loss, you do a serum p-tau 217. It's positive. It is MR. It's Alzheimer. So we have now basically a biomarker for Alzheimer's, same for p-tau for Parkinson's disease, synuclein for Parkinson's, and so on. So now we think that with MS, we already have very specific biomarkers, the central vein sign lesions, the paramagnetic rim lesions on MRI, and so on. So we want to move from a clinical diagnosis of MS, relying on symptoms, on dissemination over time, showing more and more lesions, to an actual biological diagnosis of MS that can be made from the beginning. So I summarize in this slide the main 2024 McDonald diagnostic criteria. We have now 6 criteria to diagnose MS in a patient presenting with the first demyelinating event. The first 2 are the 2017 old criteria, which is documenting dissemination in space in 2 topographies. And now, as I'll show you later, we added the optic nerve as a 5th topography. So now it's 2 out of 5 topographies, which are, remember, juxtacortical, periventricular, infratentorial, spinal cord, and now optic nerve lesion. Plus dissemination in time, showing GAD-enhancing lesion in the beginning or new T2 lesion on follow-up. And of course, we have the dissemination in space plus positive oligoclonal bands. So oligoclonal bands was already in 2017 replacing the dissemination in time. Now we have 4 new criteria. If you document dissemination in space in 4 out of 5 topographies, this is enough to diagnose MS. We don't need anymore the dissemination in time. If you have dissemination in space, again, the presence of 6 lesions with central vein sign will replace dissemination in time. If we have only 1 topographies, 6 central vein sign lesion can replace the second topography, and a single paramagnetic rim lesion can replace the second topography. So now we have 6 criteria to diagnose MS, including some of the very specific biomarkers, which are the central vein sign lesions and the paramagnetic rim lesion. For the central vein sign lesion, we selected the select 6 criteria, which means 6 central vein sign lesions. But in case you have less than 6 lesions on the whole MRI, then the more than 50% of the lesion should have a central vein sign to confirm the diagnosis of MS. So since MS is a biological disease, we think now that RIS is actually now part of the MS spectrum, and it's actually the beginning of the MS spectrum, not the CIS anymore, the radiologically isolated syndrome. And now in a patient presenting with multiple white lesion on the MRI suggestive of MS without any symptom, we can diagnose MS by one of the 3 criteria: dissemination in space plus dissemination in time, dissemination in space with oligoclonal bands, or dissemination in space with 6 central vein sign lesions. And once we diagnose the RIS with these, then this is MS, which opened the way actually to start a treatment in these cases. So number 1 now, RIS is the beginning of MS as part of the spectrum of the biological disease. We've tried also to unify the diagnostic criteria. You remember we had different diagnostic criteria for RRMS, for progressive MS, and for pediatric MS. Now, the diagnostic criteria are unified the same for all of these MS cases. In primary progressive MS, now we apply the same criteria that I showed you, the 6 criteria as RRMS. However, the only difference is that if you have 2 spinal cord lesions, these are enough to fulfill the dissemination in space criteria. You don't need brain lesions. Why? Because as we know, many of the primary progressive MS cases present as a spinal cord syndrome with minimal brain lesion. In pediatric MS cases, you remember we used to rely on the group criteria. Now, the same relapsing remitting MS criteria should be used to diagnose MS. However, the only exception is, or the only nuance is, in patients that are under 12 years of age, studies have shown that in patients under 12 years presenting with CNS demyelinating disorder, 50% of them turn out to have MOGAD, or MOG antibody disease. So we added that in patients under 12 years of age, besides applying our criteria, we should document a negative MOG IgG antibody. And finally, in the middle here are the criteria to avoid the most common misdiagnosis that I mentioned initially in our Minactrim study. So in patients that are more than 50 years of age, in patients that have multiple vascular comorbidity, hypertension, diabetes, smoking, and so on, in patients with vascular migraines, all of these cases where you can have multiple white matter lesions, which can be confused with MS and actually are the cause of the most common misdiagnosis. So in this category of patient, we recommend, besides applying the criteria, having one of these three additional criteria, either a spinal cord lesion or oligoclonal bands or 6 central vein sign. And this way we can increase the specificity of the diagnosis and avoid these most common misdiagnoses that I mentioned. So let's go over this addition. Number one, we added the optic nerve as a fifth topography. And this is a case presentation that will illustrate the importance of this topography. So this is a 34-year-old lady. In September 2024, she presented to my clinic with a left optic neuritis. We gave her steroids, she recovered completely. On physical exam, the only finding was that she had some sensory loss in the left lower extremities. Her visual evoked potentials were normal, but she had oligoclonal band positive lesions. So remember, optic neuritis with positive oligoclonal bands. We did the MRI and we could see here multiple periventricular lesions, but no infratentorial lesions, no juxtacortical lesions. And when we did the spinal cord MRI, she had no lesions. So ultimately, we ended up with a patient with a single topography, which is periventricular, but she has optic neuritis with oligoclonal band. So we know this is going to be MS ultimately. However, when we did the brain MRI, we were able to see, you can see here, a lesion in the optic nerve, which was actually enhancing. So is this MS? If you look at the 2017 criteria, optic nerve was not a topography. So in this case, we only had one topography, but we had the oligoclonal band to replace dissemination time. So we could not fulfill the criteria for MS. But now in 2017, since optic nerve is a topography and we have the lesion on MRI in the optic nerve, now we have two topographies, periventricular and optic nerve, plus the oligoclonal band replacing dissemination in time. So the patient now can fulfill the diagnostic criteria for MS. This is another patient. She's a 24-year-old lady presenting this time with a myelitis. If you look at the brain, we can see subcortical lesions, but they are not juxtacortical. Remember, a juxtacortical lesion, you should not have any rim of white matter between the lesion and the cortex. And here we can see a rim. So this is not a juxtacortical lesion. These are subcortical. But looking at her spinal cord, she had multiple spinal cord lesions that were typical of MS, and her oligoclonal bands were positive. However, her OCT and VEP were normal. So we know this patient is going to ultimately be MS. However, if we look at our 2017 criteria, we cannot make the diagnosis. Why? Because she has only the spinal cord lesion and the oligoclonal band, but we don't have a second topography. So this is the double inversion recovery MRI, and we can see here she has bilateral optic nerve lesion. So now we have a second topography, spinal cord plus optic nerve, fulfilling dissemination in space, and the oligoclonal band replacing dissemination time. And now we can, in 2024, make the diagnosis of MS in this young lady presenting with myelitis. Let's move to primary progressive MS. So as I mentioned now, it's a unified criteria. We can apply the same criteria for relapsing remitting as to primary progressive MS. And of course, as usual, we should document evidence of clinical progression over at least 12 months. And the only exception or nuance or change is that two spinal cord lesions can provide evidence of dissemination in space without any brain lesion. So let's look at this other patient. This is a 47-year-old male who was experiencing a slow worsening of his gait over the last 2 years. So we have evidence of the progression over more than 12 months. And on physical examination, he had a left leg, left lower extremity weakness with brisk reflexes and a Babinski sign. And his EDS score was already 2. We don't have any CSF oligoclonal band. He probably refused to have his LP. We did the spinal cord lesion, the spinal cord MRI, and we saw 3 spinal cord lesions. However, his MRI showed only 2 subcortical lesions. So we have evidence of dissemination in space. This is a primary progressive MS with progression over more than 12 months. So we have the dissemination in space by the spinal cord lesions, 2 of them, but we don't have a second topography to confirm the diagnosis. And of course, we don't have the evidence of the dissemination in time. So based on the criteria of primary progressive MS in 2017, the patient does not fulfill the criteria. However, when we looked at these 2 subcortical lesions, both of them had a central vein sign. And remember what I told you, if you don't have a total of 6 white matter lesions on the brain MRI, then the more than 50% of the lesion should have a CVS. And in this case, it's 2 out of the 2 brain lesions with a central vein sign. So basically, as you remember, the 6 central vein sign criterion can replace dissemination in time. So we already have 2 spinal cord lesions to fulfill the criteria for dissemination in space since it's PPMS. And now with the central vein sign lesion, we are fulfilling the IT. And now with the 2024 criteria, we can diagnose MS in this patient and probably start treatment already. Now, the central vein sign is one of those very specific biomarkers for MS that will help us make these diagnoses as a biological disease. If you remember the pathology of MS, this is basically an H&E stain showing the central vein and the extravasation of all the inflammatory cells around it, producing demyelination. And this demyelination will start spreading centrifugally as the inflammatory infiltrate start growing out of the central vein sign. And you end up with a tube of demyelination around the central vein. So the central vein sign is really reflecting the actual pathology of MS. And luckily enough, we can see the central vein, any vein on the MRI, because the veins are paramagnetic because of the iron present in the RBCs. And these are examples here where you can see on the SWI or T2 star sequence, the central vein sign in this lesion. And then when they looked at the MS patient versus non-MS, the presence of 40% of the lesion with CVS completely differentiated MS from non-MS. You can still see a central vein sign lesion in NMO, in MOGAD, in Bahjat, but the issue is the presence of 6 lesions or the majority of the lesion having CVS becomes very specific to MS. So for the first time, when we look at this white matter lesion in the brain, we can say that this is an MS lesion, not migraine, not vascular, not a hypertensive infarct, because now we have a very specific biomarker reflecting the actual pathology of MS. And this is another case to illustrate what I'm talking about, a 43-year-old man presenting with numbness in his right leg. We do the brain MRI, we can see a juxtacortical lesion touching the cortex, we can see periventricular lesions, and we can see a spinal cord lesion. So we actually have 3 localizations. However, there were no GAD-enhancing lesions, so no dissemination in time, and we don't have oligoclonal bands. So we have the dissemination in space, but not the dissemination in time. So what we did, we looked at all these subcortical lesions, and we found that most of them had actually a central vein sign, as you can see here. So we documented 6 lesions with central vein sign. So we already have the dissemination in space. And as I mentioned, the 6 central vein signs can replace dissemination in time. And this is how, in this case, we can make the diagnosis of MS. The paramagnetic rim lesion is another lesion that reflects the actual pathology of MS, a very, very specific biomarker for MS. This is a luxol fast blue stain of the brain, and we can see here the myelin in blue and the loss of myelin here in this area. This is the myelitic plaque. But if you do a Belchowski stain for iron, we can see that the rim of this lesion is full with macrophages and microglia that are iron-laden. And this is what we call the paramagnetic rim lesion, or the slowly expanding lesion, where this rim of macrophage and microglia keep expanding this lesion slowly, eating up the brain. And this is really probably the correlate of smoldering disease of progressive MS in the brain. So since these are iron-laden microglia and macrophages, then we can see it as a paramagnetic lesion here, and you can see on the SWI the paramagnetic rim. And the paramagnetic rim lesion are extremely specific for MS. Even a single paramagnetic rim lesion has almost 100% specificity for MS. We only see paramagnetic rim lesion in one other disease, which is Tay-Sachs disease, and this is the only one. This is an example of how to use the paramagnetic rim lesions. This is a 33-year-old woman presenting with an optic neuritis, positive oligoclonal bands, but no enhancing lesion. And on the MRI, she has only a single periventricular lesion. So we have the oligoclonal band, but a single periventricular lesion. We don't have a second topography. We look at the SWI, and we can see that this lesion is actually a paramagnetic rim lesion. And remember, a pearl will replace a second topography. So we have a periventricular as one topography, the pearl as a second topography, DIS is fulfilled, and we have the oligoclonal band, and now we can make the diagnosis of MS. Finally, the kappa-free light chain. What are the kappa-free light chains? When the B cell produce antibodies, the antibodies are made of light chain and heavy chains. And these are the IgGs that deposit as oligoclonal bands in the CSF. However, when the B cell is producing the IgG antibody, it produces an extra number of free light chain, the kappa-free light chain. So kappa-free light chains and the oligoclonal bands have the same origin and the same significance. However, the difference between the two is that it's much easier to calculate the kappa-free light chain index in the CSF. It's a simple metric. Measurement. It's very easy and fast to do. It's rater independent. And if you look at the oligoclonal band, they are really very tedious. You have this gel electrophoresis. The lab technician in the lab has to look and calculate the oligoclonal band, make sure they are not present in the serum. So it's labor intensive, it's rater dependent. However, both criterion have the same sensitivity and specificity for MS, as you can see here. So in the new diagnostic criteria, we introduce the kappa-free light chain index that can be used in the CSF interchangeably with the oligoclonal band. So in conclusion, the importance of diagnosing MS early is that you can now treat it much earlier. And treating MS early, as we can see here, leads to much better outcome. And this is why over the last 20 years, we really changed completely the natural history of MS. Number one, by these diagnostic criteria, diagnosing MS early. And number two, by introducing high efficacy medication early on. And we can see here from this graph, the number of patients reaching EDSS-6 or walking on a cane by age 50, if we look at our patient in the 90s, almost 30% of them by the age 50 were on a cane. But if we look now in the 2016 and above, almost 5% of our patients by age 50 are on a cane, a huge change in the natural history of MS. Thank you very much, and we all expect you to be with us in the Minectrim Congress in Dubai in December. Back to you, Jihad.
Thank you, Professor Yamut. Very interesting presentation. We are waiting for the guidelines or the 2024 criteria to be published. Hopefully, we'll see it soon. For your information, we have more than 813 participants, so we have a huge number attending and listening. And we started getting many questions, so we'll gather them at the end. So we now go back to Dr. Ahmed Shatila. I presented him initially at the beginning. He's a consultant neurologist, senior consultant neurologist at Sheikh Shakhbout Medical City. And he's the chair of the MS section there. And he is the chair of the Advisory Medical Committee of the National MS Society. And he will be talking about an era of abundant disease-modifying therapies for MS, an era of abundant choices. So it's very interesting. The conclusion is very interesting. I know it. So please, Dr. Ahmed, the stage is yours.
Thank you very much, Dr. Jihad. And once again, thank you everyone for joining. I just would like to reiterate Dr. Bassem's point on his presentation. And truly, the introduction of DMTs have changed how we treat MS and have changed outcomes. You know, when I was a medical student back in the early 2000s, more than 50% of the people in the MS clinic were in beds or on wheelchairs. You fast forward to 2025, You can't tell who has MS versus who doesn't have MS in the neurology clinic. And alhamdulillah, the medicines have made a dramatic improvement in the quality of lives of people with MS. So thank you, Dr. Bassam, for the previous presentation. I will now try to share my screen. Replace, there we go. There we go. Make it full screen. Okay, let me hide this panel. Hide floating. Okay, so
Yeah, okay. We see.
So I'm going to talk about disease-modifying therapies for MS, an era of abundant choices. And that's exactly what we have. We have a lot of choices. So then how do you choose? Hopefully you'll get a better idea by the end of this presentation and the next one's coming up. Okay. So when we look at the MS treatment, the landscape has changed. The landscape has changed dramatically just from in the past 30 years. You know, from 1995, the first interferons came out, interferon beta 1b. And then over the next couple of years, we get a bunch of other interferons, sub-Q, IM, other sub-Q. And then, you know, Copaxone, copolymer came out in the early 2000, and then natalizumab in the 2005. And then it became quiet. Fingolimod came 5 years later. And then after that, so in the first, you can see from 94 till 2010, you only had like 2, 3 different modes of actions. You had the interferons, you had the copolymer, you had natalizumab and fingolimod. So natalizumab and fingolimod are both sequestering agents. Copolymer, no one quite knows exactly how it works, but it works on myelin basic protein. So that's the second mode of action. You have all the interferons. So you have 3 mechanisms to treat MS in over 15 years that were developed. And after 2010, you see this explosion of medications. We have new sequestering agents, new immunosuppressants. We have selective immunosuppressants, broad selection immunosuppressants, and then medications that work in the brain, some peripherally. So it's gotten extremely complicated. And we went from immunomodulatory to immune reconstitution to continuous immunosuppression. So the landscape has changed dramatically over the past 30 years. So how do you choose? You know, there's always that balance. You've got efficacy on one side, you've got safety, and you've got tolerability. The best medicine would be the most safest, the most efficacious, and the most tolerable. Unfortunately, we don't have that. We usually have to give up one to get the other. You may get something that's very efficacious, but maybe not very safe. Or you may get safe and efficacious, but it's not very tolerable, the side effects. We don't yet have that ideal golden medicine that gives you all 3. It's getting closer, we're getting better, but you know, now we're also starting to realize that patients may want to sacrifice, or they may be willing to sacrifice one for the other. And I'll talk a little bit about that later. So why do we want to start treatment early? Dr. Bassam already told you, you start early, you do better. Study after study shows the same thing. On the red line, it shows that people that were started late, 4 to 6 years after disease onset, they were more likely to get disabled faster than the people that started early, 0 to 2 years of onset. So, and this has been repeated over and over again. Another study where they looked at conversion to SPMS. This was actually from the alemtuzumab trials. So what happened was people treated with alemtuzumab, you look at what proportion of people by year 9 are converted to MS versus the platform therapies, and you notice there's a significant difference. Now, by the way, the alemtuzumab trials or the TOPAZ, we're on like year 12 or 13 now. Every year it gets updated, and every year the data looks just as good as the year before. So this is we're starting to see a trend, and this curve separates more with time. So less people SPMS, more people who weren't treated develop SPMS. So there is even more divergence of these curves. So let's talk about high efficacy therapy. The first one is cladribine, the mechanism. So how does cladribine work? It basically works on the enzyme adenine deaminase, ADA. For all of y'all that don't remember ADA, go back the boy in the plastic bubble, the kid that had to live in a plastic bubble because he didn't have an immune system. What does cladribine do? It kind of does similar. It attacks that enzyme that causes adenine deaminase deficiency. It causes purine buildup in the and the lymphocytes, causing slow apoptosis. So you give it orally, it's weight-based. It causes a decrease in your lymphocytes. It's not a lytic medicine. You don't get all the lymphocytes dead all of a sudden. You get slow apoptosis over the next couple of weeks. So you see this gradual reduction of lymphocytes. But then what happens? You're not taking the medicine anymore, and it wears off in 7 days. But yet when the immune system comes back online, a couple months later, it's different. You have less memory cells, more suppressor cells, and the disease itself is not the same disease, even though you only received 5 days of treatment first month. I'm sorry, you've only received 10 days in the first year and 10 days in the second year. So what does that look like? You have around a 58% reduction in the annualized relapse rate when they looked at it versus placebo. You have a 50% reduction in 6 months confirmed PDSS progression. You have almost 86 to 90% reduction in GAD-enhancing lesions and 73% reduction in T2 lesions. So like I said, even though the medicine is given over 20 days, you see a significant effect a couple years later. And that's how it is. It's given 3.5 milligrams per kilogram over 2 years, 1.75 in year 1, 1.75 mg per kg in year 2. Now, what you'll look at here, this was the Clarity 1 and the Clarity Extension. What they looked at was the proportion of people that were relapse-free. So 77%, almost 78% of patients were relapse-free in the first year. But by the end, in year 3 and year 4, they weren't taking medicine. The number didn't change. So that is why now cladribine is not a continuous medicine. It's considered an IRT. You give it, something happens with the immune system, and when it comes back online, it's different. So let's talk about the other medicine. Natalizumab. It's a highly potent, I'm sorry, let me just turn this off. I'm getting a weird mess. Okay, natalizumab. It came out around 2005. And how does it work? It works on the VLA4, the alpha-4 integrin and molecule or receptor. What it does is it binds to alpha-4 integrin. And what does alpha-4 integrin do? It binds to VCAM. VCAM, basically, you need the lymphocytes to bind to the VCAM receptor on the epithelial cell so that you can get what we call diapedesis. That's when the lymphocytes go from the blood to the brain. It blocks that, so now you don't get that transition of lymphocytes from the blood to the brain. If you don't get those bad lymphocytes in the brain, they don't cause lesions, and that's why the disease gets under control. But also, if you have lymphocytes in the brain, it also blocks the VCAM or the alpha-4 integrin, so they can't bind to any nerve cells in the brain. So you get a peripheral, and you get, to a lesser extent, a centrally acting medication. So how does it work? It is highly effective. If you look at the annualized relapse rate in the study, you have almost a 70% reduction in the annualized relapse rate in the first year, and it's sustained in the second year. The cumulative disability progression, 42% of people, 42% less disability progression versus placebo. It's highly active. It definitely suppresses the immune system, and it suppresses disease activity. How's it given? It's given 300 milligrams IV infusion over 30 minutes every 4 weeks. Some studies are saying that now we can give it every 6 weeks, but that is not. We do give it, but according to the label, it's every 4 weeks. Now, if we look at what's the long-term data, we got the Tysabri observational program, the TOP study. This has been a yearly study that's been going on for more than 10 years, looking at the annualized relapse rate of people who received Tysabri and right in the very beginning and how they know. So you'll notice right before Tysabri, they had an annualized relapse rate of 2 relapses a year. In current definition, that is highly aggressive disease. If you have 2 relapses a year, you have aggressive MS. By the first year, it's now 0.2. That means now you have 1 relapse in about 5 years. Now, if you go to year 10, it's 0.04 relapses per year, which is almost one relapse every 25 years. So this medicine does work. But now, at what cost? I was telling you, you got safety, efficacy, tolerability. So it's very efficacious. It's pretty tolerable. You give it IV every 4 weeks, and now we got a sub-Q version. But the safety is what kind of hit Tysabri in 2005, and it became kind of something that it's always been haunting Tysabri. It's PML. So back in 2005, there was around 2 cases of PML that were reported in New England Journal of Medicine. It was initially taken off the market, but then neurologists felt, or the panel felt, that since this medicine was so efficacious and it truly could change the way the disease works and operates, it would be a shame not to give it back to patients. But it was brought back on the market with some restrictions. You have to be registered in the TOUCH program by Biogen in order to follow your JC virus. And around 2011, there was a JC virus. Then we started getting indexes, and now we're learning more and more about who can get JC virus or who can get PML. JC virus is endemic. It's like mono. Around 70% of people just have it. How do you get it? You just get it. If you have it, though, you have a risk of that developing into progressive multifocal leukoencephalopathy, PML, around 4.1 per 1,000 patients. But not everyone with JC will get PML. What are the driving factors? If you're on the medicine for more than 2 years, you have a higher risk. If you were previously treated with immunosuppressants, your risk becomes higher. And of course, if you have JC virus, you can get PML without the virus. If you have those 3, your risk definitely increases, and it increases with time. Now, we do have an index, we do have a way to follow, but that is something you need to follow with Tysabri. Now I'm going to go to alemtuzumab. Alemtuzumab works against CD52. CD52 it's on T cells, it's on B cells, it's on macrophages. What it does is give an IV, 1 dose for 5 days. You stop, you repeat it in year 2, 1 dose over 3 days. This is a lytic medicine. You give it, your lymphocytes will go from 1,000 to pretty much 0 within a couple hours. I mean, I've seen it. I've given around 70 patients alemtuzumab. It works and it works fast. But now what happens? You're going to get the lytic syndrome. You're going to get the fevers, the chills, the nausea. You may get tachycardia, you may get hypotension. So you got to observe and watch for the lytic syndromes. How does it work? It works really well. It was compared in the initial CARE-MS2 trial against interferons, and there was around a 50% reduction in annualized relapse rates. And if you look at the 6 months time to relapse, also there was a significant difference. Now it went from initially you had the CARE-MS trial, you had the CARE-MS1, CARE-MS2. They combined them in the extension trial, and then it went into the TOPAZ. The TOPAZ now, it says year 8, we're almost in year 12. And now the thing I usually tell my patients, if you get alemtuzumab, by the end of 12 years or 8 doses, around 50% of people will not need another DMT during those 12 years. 70% of people will either be stable or improved after 12 years. But now, what are the safety profiles? I told you the infusion-associated reactions are huge. Fever, chills, nausea, tachycardia, hypotension. They are mild, they are treatable, but you got to keep an eye out for them. Infections can happen. So it's a little bit more common with Lemtrada, but they are usually mild and respond. We do give acyclovir 200 milligrams BID for 60 days after your alemtuzumab to prevent shingles. You got to make sure you're vaccinated. Autoimmune, the problem with alemtuzumab, you get a rebound in your B cells. So you get complete B cell, T cell suppression. But then when your immune system comes back online, your B cells come back first. And the problem is you need T cells to control your B cells. So now you have a bunch of B cells that aren't being controlled, and you kind of like suppress one immune autoimmune disorder, and you get 3 others. You can actually get more, but the 3 most common is thyroid, which can be up to 50% in 5 years, ITP around 1%, and of course, anti-GBM nephropathies around 1 in 1,000. Now, usually the risk of getting this are high in the first 5 years. After that, they tend to drop down to 0. So what do we say? You have to do monthly blood tests, urine tests, and TSH levels every 3 months for 4 years after the last dose. Now let's go to B cells. That's another way of looking. That's another treatment. I told you it's going to get complicated. We've got B cells. So we've got T cells can work. B cells work. Combination works. You can trap the immune system with your natalizumab or fingolimod. And now we have a different class of medication, the B cells. B cells, we know that in the immune system, you have these follicles of B cells in the meninges, and they tend to be CD20. If you attack CD20, affect T cells, they produce cytokine, and they actually are in the brain itself, and they can drive inflammation centrally. So what's the first study? Ocrelizumab, it selectively depletes CD20 cells. Now, if you look at the CD20 cells, you start with the stem cells, you end up with the plasma cells. Stem cells can be whatever you want, blood, bone, immune system, any cell from stem cells, right? And your plasma cells are what makes up your humoral immunity. That's what keeps you protected from viruses 20 years after you get the virus, right? Well, ocrelizumab kind of kills everything in between. It doesn't kill your stem cells, and it doesn't kill your plasma cells, but it does kill everything that gives you plasma cells. So that's how it works, CD20. How does it work? It works pretty effective, very effective. In the OPERA-1 trial, it was compared against interferon, and there was around a 50% reduction in the annualized relapse rate. This is not against placebo, this is against active competitor. OPERA-2, same study, same medicine, same interferon, around 47%, so it was sustained. Now we're going to go to, well, it was approved for relapsing remitting MS, but then that was OPERA-1, OPERA-2. But then you had the oratorial trial, which looked at PPMS, primary progressive MS, and this is the only medicine today available on the market that treat patients with primary progressive multiple sclerosis. How did it do? It actually had a 24% reduction in time of 12 weeks confirmed disability, and it had around a 25% reduction in a 24-week confirmed disability. Now you're going to say, well, that's not a lot. But if you go back to the days of the interferons, that's what the interferons were doing 20, 30 years ago, around 27%. Is it the 90% we have now? No, but it's a start. It's something we didn't have a couple years ago, and that's how I look at it. So now we go to a different type of B-cell medications. So rituximab works on B cells. It was made in 1997 by Roche. Then they said, well, it works, but can we do better? So then they made ocrelizumab, which is rituximab was chimeric. It had some mice in it, mouse. Chimeric, more human, less mice. Ofatumumab is fully human, and the name says it all. Anything with Zmab is usually chimeric. Zumab is humanized, and Mumab is human. So Zizumu. How does it do? It is highly efficacious as well. This was compared against teriflunomide, active competitor, not placebo, in the Asclepius-1 and Asclepius-2 trial. You had a 50% reduction in the annualized relapse rate in Asclepius-1 and a 58% in Asclepius-2. Side effects were tolerable, no red flags. So now we're going to go to I'm almost done here. I'm talking a little fast because there's a lot of slides. So we got to balance efficacy versus safety. As healthcare providers, sometimes we want something that works, but we don't want something we don't want anything that kills our patients or that could potentially kill our patient. So we may go with something more safer, even though it may not be the most efficacious. And if you go with MS treatment, around 20 years ago, it was recommended with this go low, go slow, and we treat as you go. You don't change until you fail medicine. But now there's been a paradigm shift in the last couple of years. Hit early, hit hard, and suppress the disease. Don't wait for it to progress. You stop it in the beginning. And I always like giving the analogy of the fire department. You don't call the fire department when your house is burned down. You call it as soon as the fire starts. If you wait for the house to be on the ground, there's nothing left to save. Same thing with the therapies. You want to stop the disease in the beginning. So why are new targets for MS still needed? Are we there yet? No, we're not. I told you we have around 20 medicines, but yet what don't we have? We don't have a lot of medicines for disability progression. We do not have anything for improvement per se. We don't have much about neurodegeneration in the early parts. And safety and efficacy long term is always something that will haunt us. We worry about, well, B cells work, B cell suppression works. But what is the long-term effect of suppressing your B cells, especially as our MS population is getting older? It's great when you're in the 20s, 30s, but what about when you're in the 60s? Do you have the same benefit? Infections, autoimmunity, and malignancies will always be something that we think about. So that's why I think we do still need more medication. The last bit I'm going to talk in the last couple of minutes is about BTKs. Bruton tyrannase kinase. So what are BTKs? BTKs are basically, they are the derivative of myeloid cells. What are the myeloid cells? They are the cells that make your monocytes, macrophages, and microglia. So what does it do? Now let's focus on, so it has a central and has a peripheral. The B cells are from the myeloid cells. The microglia, the macrophages, the dendritic cells are also from the myeloid cells. If you can prevent or stop BTK, you can prevent development of these cells and potentially stop inflammation. As Dr. Bassam said, the lesions are heavily iron-laden macrophages. So if we can kill the macrophages, you may stop that smoldering MS. So what studies do we have? Right now, we have around 6 medications that are being studied. If just a little point, remiprutinib is currently, I'm in a phase 3 clinical trial at SSMC, where we are looking for people to be enrolled in remiprutinib for relapsing remitting MS. If you have anyone that's interested, send them over. So I'm going to talk about the safety and efficacy of toloprutinib versus teriflunomide. This was a phase 3 trial, Gemini 1 and 2, and I have 1.5 minutes to do this. So what was it? It was a double-blinded, double dummy, meaning that both groups were getting a treatment and a placebo. Nobody knew who was getting what, neither patient or physician. And you basically, what were the inclusion? You had to have MS, you had to have 1855, an EDSS of less than 5.5, and you had to have active disease, because how do you tell if a medicine works? You got to have the disease that's active. How did it do overall? There was no difference in the annualized relapse rate in toloprutinib versus teriflunomide. But what it did show, there was a reduction in 6-month confirmed disability worsening. So this kind of goes to the idea that it works against inflammation just like teriflunomide, but it appears to be affecting that myeloid-like cell or the macrophages in the CNS that may be more for the chronic disease. So then what did they do? They looked at another study, the efficacy and safety of toloprutinib versus placebo and non-relapsing secondary progressive MS. And this is a really interesting study because we do not have any medicines that were really studied in any phase 3 clinical trial for this issue. So how did it do? It looked for, basically it was double-blinded, double dummy. It was an event-driven study, meaning that if you were less than 50, you had to have at least a 1-point change in your EDSS to say that you're getting worse. If you're older than 50, it was 0.5. And if you met that event and you were out of the study. So how did they do? Final conclusion, it showed a 30% reduction to time to 6-month confirmed disability versus placebo. It also increased the possibility of achieving 6-month confirmed disability improvement. So stop progression, and it actually could potentially cause improvement. And it significantly lowered the annualized relapse rate of new and enlarging T2 lesions. Liver enzymes were observed, but they tend to go back normal, and the vast majority of cases resolved without sequelae. So what do we do first? Now we got to triage our patient. I told you we have like 25 medicines. So how do we try to figure out what's the best medicine? We may look at bad prognostic, good prognostic indicators. Who are the good prognosis? Women, non-smokers, lower BMIs, monofocal, like optic neuritis, or just an isolated myelitis. You don't get a lot of relapses in the first 5 years. You do better. You have a long time till your second. You do better. No disability, of course, those are going to be more milder. No oligoclonal bands tend to be mild, and you have a mild burden. If you have those are usually good prognostic factors. You have the opposite of it, those are probably the bad prognostic, and those are the people that you want to be a little bit more aggressive on. And with that, I'd like to conclude 26 minutes and 40 seconds, Dr. Jihad. I apologize.
Thank you, Dr. Ahmed.
There was a
The
lot to talk
IVP,
about.
the society is generous with you. Very nice, informative presentation. We already reached 969,
Wow.
997, so about 1,000 participants. And I'm getting many questions about the CME. I have been notified by the IVPN. All participants will get CME accreditation. You'll get a certificate within 1 week. And second point, they are asking about recording of the lectures. Recording of lecture will be available on the IVPN website. So you can go to the website and review the lectures. Not today, later. And we move to our next speaker. It's my pleasure and honor to welcome and introduce our next speaker, Professor Anu Jacob. He's going to talk about from international standards to UAE national guidelines in MS treatment. Professor Anu Jacob is the director of the multiple sclerosis and autoimmune neurology at staff physician at the Neurological Institute in Cleveland Clinic, Abu Dhabi. Prior to joining Cleveland, Professor Jacob was consultant neurologist at Walton Center for Neurology and Neurosurgery in Liverpool in UK. He completed his neurology training in prestigious Indian and UK institutes and his multiple sclerosis and neuromyelitis optica and fellowship at Mayo Clinic in Rochester, Minnesota. Dr. Jacob, was director of multiple sclerosis for North Wales and founding director in the United Kingdom and now chief specialist service for neuromyelitis optica. He was awarded the Royal College of Physician Excellence in Patient Care Award for his work. He published more than 100 peer-reviewed research articles. One of them is the national guidelines. So he's going to talk about from international standards to UAE national guidelines in MS treatments. Professor Jacob, the stage is yours. We are happy to listen to you.
Good evening, everyone. Thank you, Dr. Jihad. Can you all see the slides and see me?
Yeah, we will see you, we hear you, we see the slides.
Thank you.
Go ahead. Thank you.
Let me move the first slide. Okay, so thank you all for joining so late in the day, and you've had a wonderful background about the criteria, about the various drugs. Now is the meat of the matter, the UAE treatment guidelines. I have no relevant disclosures, and everything that I'm going to talk about is available online for free. This is the UAE guidelines. The QR code will help you get it. It's free to download. So please do have a read. We can only go through an overview of these guidelines today, but I hope this will stimulate you to read it further. As a background, I must say a little bit about UAE, the MS here and the MS care. So many of you might be outside of UAE. There are 10 million people in UAE, about 1 million Emirati nationals. It's a moderately high prevalence of MS region. We have a high GDP, almost actually higher than in the whole of Europe. Healthcare resources are widely available, but it's public and private. I must say it's a non-equitable distribution of healthcare and varying insurance coverage. We do have primary care and there are referral systems, but they aren't really well developed. And it's fair to say that most neurologists in UAE are general neurologists, probably like many of you. So that is the context. And when the National MS Society was formed, one of their priorities of society and the panel was to generate a guideline that will facilitate treatment across UAE. And the philosophy was to facilitate the most appropriate DMT to the widest number of MS patients. We wanted to give a crisp summary of the current understanding of MS. It should be easy to understand, just pictorial, really, an algorithmic approach. It should be pragmatic. It should be really doable in real life. We should have no hesitation or shame in adopting the best elements of all the available guidelines. And while we should use existing evidence as it is, but sometimes it is okay to make common sense, logical discussions based on our understanding of the biology, because some trials may never happen. I cannot foresee a trial of rituximab versus ocrelizumab in the near future. We think they work equally. And it may take many years to get proper answers about large trials about RIS or AHSCT. So it makes sense to kind of use our common sense to say this is what is going to happen. Let's use it for the time being. But we must take care that such extrapolations should be within reason and within limits of user acceptance. We cannot really make very wild assumptions. There are, of course, going to be certain areas of ambiguity, and we have no hesitation in saying that we don't really know the answer, and we're going to state it rather than evade it and don't talk about it. Let's be practical about this, because ultimately we want to empower physicians who see patients every day in clinic and help them move forward. Physicians can say, we don't know the answer to this because the guidelines say so. And if any of you have been involved in developing any kind of guideline within your hospital systems or clinics, you will understand these are the issues. In MS, particularly with subtypes of MS, we have to accommodate that. Severity of MS, that is mild, moderate, aggressive, the various drugs, their efficacy and safety. There are various unknowns about the drugs and the disease biology itself. What about regulatory endorsement? If we make this guideline, who's going to accept it? What about the other guidelines? What about cost? What about patient preferences? And what about the biases of the panel itself? There are members of the panel, and we might have our own practice, our own preferences. How is that going to bias this UAE guideline? So we thought this over, and we realized that we are going to make our guideline what is best for patients. And this is for our region. And we will let our regulator decide if this is appropriate. And we'll take it from there. We're not going to rely on anybody else. What about the cost? Well, it's not really the panel's concern. We're going to think what's best for the patient and let the state, the manufacturer, and the insurance decide what's best. And patient preference is not in the panel's hands. The rest of the issues, I think we will solve as I present the next few slides. So first thing was to classify MS. And we used the established guidelines. We used RIS, CIS, and RRMS. And I know a lot of change might have changed in terms of the new diagnostic criteria, but it's only strengthened us. Many of these cases that we called RIS before now becomes relapsing MS. So it's become easier to treat those patients. And there are some patients who we still cannot call MS, even in the new criteria, which we can treat if they do have what the old criteria said RIS. We then wanted to define what are the pro-prognostic factors in relapsing MS. And using these two, the phenotype and the prognostic factors, we can then divide the relapsing MS into subcategories: rapidly evolving severe MS, highly active MS, moderately active MS, and a category that we would call low activity MS, because if you have clinicians, you will realize that there are people who have relapsing MS and their scans haven't changed. They're on any treatment, their scans haven't changed, their MRI hasn't changed for a few years now. And do we really have to treat these patients? So there is an area of uncertainty, and we accept that. So as we go along, there are some star marks which will tell you that there are areas that have not been touched upon by any other guideline. So this is one area that we wanted to highlight. This low activity MS is something that other guidelines have not discussed at all. So we accept this and we included this. Then we gave a certain background information that there's a foundation of these treatment guidelines. There are 25 consensus statements. I've highlighted the relevant bits of these. I'm not going to go through all of them. So we say that the inflammation predisposes to early degenerative changes. The window of opportunity is early in the course of the disease. We feel that DMTs that are more effective in controlling relapses will have more impact on delaying progression. And we can only extrapolate that short-term benefits will have long-term impacts, 10, 20 years impacts. We feel that off-label license medications are justified in many occasions. We decided to go away from individual drugs and decided to think of them as drug classes. We divided them into moderately effective and highly effective. We want to talk about drug classes, CD20 antagonist, S1P inhibitors, rather than take out individual drugs and talk about their relative merits. We know in practice, they all pretty much work very similarly. Most of us do think that rituximab, rocatinlimab probably work quite similar. The mechanism is here. They all make the B cells go to zero. So why should they be any different in terms of efficacy? So these kind of philosophies have guided us into making this guideline more pragmatic. We accept that the aim of the treatment is to achieve NEDA, no evidence of disease activity. And the evidence of ongoing disease activity is a reason to switch treatment, which is also, and we have clearly outlined how to do that. We toyed with the idea of escalation versus induction, and we realized that majority of cases that we call a so-called benign MS end up not being benign, and time lost is not regained. Therefore, we prefer more often than not a higher efficacy treatment rather than the platform therapies. Now, this is a very important figure, I think. Nowhere else have they made this kind of honest statement, honest figure that basically puts all the drugs on an efficacy versus safety chart. And we can see that the safety is on the x-axis. The more towards the right you go, it becomes safer, and efficacy is on the y-axis. So beta interferons and glatiramer are very safe, but their efficacy is quite low, 30%. And the HSCT and mitoxantrone are quite highly effective, but they are highly toxic. And it's a spectrum, as you can see. And you can see that we have clubbed all these medications here in one group, all the anti-CD20s here, the S1P inhibitors here, the fumarates here, and so on. So this gives a clear pictorial representation for the general neurologist and MS physicians to show the patients even where their choice lies. Coming to the algorithm, so this is the various categories of MS up there, RIS, CIS, the low activity MS, the various types of relapsing MS. And we can certainly treat RIS in some categories. If there's ongoing MRI activity, certain kinds of CIS, low activity MS, we don't know an answer. It is okay to treat if the patient wants something, but it's okay not to treat too. In moderately active MS, you have these options. We can go either the milder medications or the more effective, highly efficacious medications, largely depend on patient choice. But once you go to the highly active relapsing MS or the RES MS, we really have to use the higher efficacy medications. We strongly believe that because time lost is in every attack, every new lesion probably leads to irreversible axonal damage, axonal transection that leads to long-term disability. So we want to use really highly effective medications early on. And once these medications fail, we have no hesitation in switching to a next line or switching sideways to another medication. We should not wait too long before too many relapses or events happen to switch the medications. And we also consider HSCT as a second line option. So there are guidelines on switching treatments because of continuing activity, because of side effects. We consider treating PIRA. PIRA, as you know, is progression independent of relapses. There aren't many good guidelines. This is the first guideline to suggest treating for PIRA. There are certain guidelines as to when PIRA can be treated. We have kept the switching thresholds quite low. We don't want patients to have multiple events in the brain. We know the brain is a big area. Small lesions, new inflammatory activity will not be reflected outside. So if you have unequivocal new inflammatory activity, we should switch treatment. If there are side effects, there are anxieties about side effects. And we also recommend that when we switch, you should go from a highly active to another highly active rather than stepping down unless you really have no other choice. For progressive MS, we recommend treating progressive MS if there is evidence of ongoing disease activity. And even if there is no ongoing disease activity in young patients, people in their 20s and 30s, I think it is reasonable to offer them DMTs because there is a good chance that they usually have a grumbling, relapsing, inflammatory MS rather than the degenerative progressive MS. For PPMS, we have increased the age cutoff for treatment, and we currently have only anti-CD20s as a treatment for PPMS. The various drugs that are approved for SPMS are outlined here, and as you will know that any drug that is effective in relapsing MS can be used for inflammatory SPMS. And to some degree, we can maybe, for PPMS, however, with ocrelizumab is the only approved treatment. So this is the algorithm for progressive MS. So we have SPMS and PPMS. So SPMS, there is inflammatory activity, none, but a young ambulatory patient, then you can treat. There is no, it's an elderly patient or an aging patient with no inflammatory activity, perhaps no treatment, but you continue to monitor. If you have for PPMS, then if it's inflammatory activity, yes, you treat. Young patient, again, if it is no inflammatory activity, also you treat. And we accept that there'll be some people who the medicines are not effective, and you should not hesitate to offer discontinuing treatment while continuing care. Because many times we realize that medicines are probably giving patients more difficulty, more cost, and affecting quality of life purely because of the money it takes away from other parts of care. So stopping treatment sometimes is appropriate. And this also has been clearly spelled out. And we say that, in relapsing MS, more than 55 years, at least 5 years of disease activity, you can consider discontinuing treatment. And progressive MS, who are continuing to progress despite being on a DMT, then it's okay to pause treatment and watch and decide if you have to restart it. I won't go into these. This is all explained in the guidelines. We are okay in using unlicensed MS DMTs, unlicensed in the FDA, EMEA sense. Rituximab in particular, azathioprine in resource-poor settings, does have some disease-modifying effect. If nothing else is available, you can use that. Rarely cyclophosphamide for very aggressive MS, or if the resources are limited. We are okay in using AHSCT as a second-line medication. You fail a high-efficacy medication like ocrelizumab or tisabri or alemtuzumab. In UAE, you can use the AHSCT if the patient desires. And if you have ongoing active inflammation in SPMS, you can certainly go for AHSCT. Pediatric MS, we have 3 approved medications, and this would be the first line. But we again understand that sometimes these medications are not enough. And just because somebody's age is 16 years old, but they do weigh 90 kilos and they are 6.5 feet tall, we should not hesitate. They should not be not given a higher efficacy medication that is unlicensed. So we are okay in using the other medications for the right patients who chronologically might be less than 17 years old, but biologically they are an adult. You're fine to use it. Even for younger patients, if there are no other appropriate agents. And there's increasing amount of data on the efficacy of these medications in pediatric MS. For DMTs in pregnancy, we have tried to simplify it and make it very clear. Again, these are clearly given in the manuscript. But to make it simple, we have given a table, and I often go back myself and look at this in clinic to see what we have said, and I find it very useful. Essentially, we have classified medications into 3 categories. Safe, where you don't have to worry at all. You don't have to, you can continue the medications till conception. Some can be continued in pregnancy. So the drug name, the last dose should be when, and what is the continuation in pregnancy. So interferons glatiramer can be taken throughout pregnancy. Tecfidera has to be stopped at conception, while natalizumab can be continued till 34 weeks. Some medications are likely safe. Again, we have given clear criteria as to when you should stop them to conceive, and then when you can restart them. And there are some medications, as you know, as you can see, it's color coded to when we can stop. We should be stopped prior to planning conception, and the times are also given there. What about breastfeeding? Again, there is 3 categories: unsafe, likely safe, and safe. We have clearly given what drugs can be used when. And this is all available, as I said, in the guideline. You can the QR code is there. Do download and keep it as a handy reference. And lastly, as Dr. Ahmed said, we send these guidelines out to various UAE neurologists, and all their comments were discussed in the panel, and we agreed or disagreed on various aspects, and they have clearly enhanced the guideline in far better than we ourselves had thought. And finally, when these guidelines were published, we were all quite anxious about what will the international opinion be on this, because we didn't really seek anybody else's opinion on this. And it was overwhelmingly positive. And from the UK, Professor Cole says, I wish we had the liberty of writing such sensible guidelines. And Jeff Cohen from Cleveland, Ohio says, I think it's a well thought out recommendations. It nicely reviews the evidence and points for which evidence is lacking or less definitive. Well done. And Brian Weinshanger from Mayo Clinic says, it's a pleasure to read all these elements put together. And of course, there are some criticisms. It's positive that RIS is included, but unfortunately enriches the current artificial classification of MS, which is true, but that is what we have at present. That's what we have to work on. Perhaps my most favorite one is this from my colleague in India. And he helps general neurologists treat MS. Thank you for democratizing MS DMT treatment. Because what he's saying is this guideline, any general neurologist can read, understand, it's algorithmic. It makes, ocrelizumab is so expensive in India, and they're saying rituximab is equivalent. So it frees them up to use the available medications, and anybody can treat MS with these guidelines. As was said earlier, they're very grateful that the society interacted with the health authorities, and it's been adopted now. And I hope I have been able to address all those issues: the subtypes issue, the severity issue, the medication efficacy issue, the unknowns and the drug biology. Hopefully we accommodated all those issues in these guidelines. So the QR code is there one more time for you to see. And I want to take a screenshot if you wanted. Now I want to summarize by saying that it is possible to create a national guidelines that are evidence-based, pragmatic, and acceptable to peers and regulators. In terms of efficacy, think of drug classes rather than individual drugs. Think of induction rather than escalation approach. Progression can be influenced by controlling inflammation. There are no effective drugs at present for the degenerative aspect. We heard about the BTK inhibitors. Hopefully that's going to come out soon. Monitoring and switching early is important. Progressive MS with evident or presumed inflammatory activity can be treated. Some low activity MS may be observed. Don't treat the patient for your own anxiety. Discontinuation is reasonable if there is no benefit. Stop DMTs, but not the care. And I want to thank you all, audience, for viewers, from our bottom of our hearts, from the authors and the MS Society. Thank you all very much.
Thank you, Dr. Anu Jacob. Excellent presentation, especially the last part. I like the opinion of the international, especially the last one from India. So now we have more than 1,000 participants. We have already many questions. I answered many of them, so I left part of them, the important ones, to the panel. So we are to the panel Q&A now. I'll start with what I feel, and you can share with me reading the questions. So because we have limited time. So the question which I found it suitable, it is directed from Dr. Basil to Dr. Basim, Dr. Ahmed. What are your thoughts on cladribine efficacy in clinical practice? Is it comparable to monoclonal antibodies? Is it highly efficacious in moderate severe disease or only in milder cases or those requiring exit therapy? So what do you think? Basim, Ahmed?
Okay. Well, I can answer, and Dr. Bascom can definitely help out. I've been using cladribine since 2017. It was FDA approved in 2018 in April. And I have more than 100 patients who have received cladribine. On average, when I've looked at the registry, the NIDA of people receiving cladribine is around 85%. I have around 85% of patients who've received cladribine remain NIDA. Now, there are some biases. Some patients received the medicine 6 months ago, some of them received it 4 years ago. But on average, we're looking at 85%. One of the things I've noticed, and the studies have kind of shown, is that there are a certain group of people that do better if you start cladribine. The younger patients, the naive patients, the ones without spinal cord lesions, the ones with a low disease burden at baseline tend to do better than the opposites. Now, is it better than the B cells? I mean, we don't have had that trials. And so when Dr. Anu put on the graph, we put it that it's on average around the same efficacy, but cladribine is probably considered a little bit more safer. Dr. Bassam?
Yes, I fully agree with you, Ahmed. So I was in the original cladribine trial like almost 20 years ago, and I have 32 patients that were enrolled in the original trial, and I've followed them so far. So we're just in a meeting in Istanbul yesterday, and I presented two of those patients who took cladribine 17 and 11 years ago and have never had any other relapses or disease activity for this whole period. And the second patient, actually, after 17 years, just had a myelitis relapse last summer after 17 years. So cladribine is an immune reconstitution therapies, and we can have patients that would respond like that excellently with a very long, prolonged control of disease. And of course, like Ahmed said, with excellent safety because your immune system is back to normal within 18 months after the start of treatment. Now, keeping that in mind, at the same time, if you look at our Minectrim guidelines and our UAE guidelines, we think that probably cladribine is a little bit lower efficacy than the monoclonal antibodies. And this is just from experience. We never had a head-to-head trial. We will never have head-to-head trial in the future, like Anu mentioned. So the ideal patient, like Ahmed mentioned, would be a treatment-naive patient coming with some of the poor prognostic factors that we put in our guidelines. And this would be the ideal patient to do an immune reconstitution and probably induce a very, very long remission. Now, cladribine can also be used as an escalation therapy from the platform therapies. But once we have a very aggressive MS or failure on higher efficacy or moderate efficacy medication, probably in that case, I don't see the cladribine place in these categories. So it is very good to be used in a certain indications. And if we use it in those indications, I think the results will be excellent.
Thank you, both Ahmed and Basim. So it is not for rapidly evolving according to our guidelines.
Right.
Yeah. The next question from Bankin Youssef. If a patient diagnosed with MS and presented to the emergency with a new attack, like problem with vision, what to do as per doctor? This big question, it is open. So if you like Dr. Anu to answer this question.
So the question is, somebody has a new MS, a new diagnosis.
Optic neuritis.
Okay, and it's about treatment.
Attack, MS patient having optic neuritis came to the emergency.
Okay, so first of all, confirm it is an optic neuritis. I know color vision, visual acuity, make sure it's optic neuritis, not something else, not a retinal problem. And it depends usually on the severity. If it is very mild and it is settling down, perhaps you can not do much. But most of the time, the visual impairment will be significant, in which case you want to give corticosteroids to improve it. Now, corticosteroids can be given either intravenous for 5 days, 1 gram typically methylprednisolone, Or we can use oral methylprednisolone as well. A tapering course is not usually given. If it's a diagnosed case of MS, then that is usually enough to improve things. If the diagnosis is uncertain, if there are possibilities of other diseases like NMO and MOG, then you want to give a tapering course of steroids. Now, some optic neuritis can be really severe. They can lose sight completely. And especially if there is subclinical damage on the other side or past optic neuritis, you want to be aggressive here and do plasma exchange. So you will have to admit the patient or arrange, day case plasma exchange. And usually it's 5 cycles, alternate days. And that usually leads to improvement. And obviously, if somebody is having MS and is on some DMT, has had a new relapse, you have to think about switching treatments.
Thank you. I know usually MS patients, they don't go blind like NMOSD, isn't it?
That is correct. Yes, usually not.
Yeah. We have another question here. Sadly, my cousin and his family refused to take treatment. I think continuation of the previous question. He was a medical student and he did his final exam during initial symptoms. After graduation, he stayed at home slowly fading away, but never stopped learning and getting knowledge daily, despite, I think he was a hero, he said, it's okay. So we'll skip the continuation with the question. Now, the next question is from Barco Bolat. Your efforts in MS field are really appreciated. We thank you for this. As for my question, we still don't fully understand neuroinflammation and neurodegeneration. And moreover, each brain is unique and has its own time. However, time is brain and hit early, hit strong approach is not always the right one in MS in every patient. What do you think, Dr. Ahmed? So hit early and strong is not proper approach in all patients. Do you agree on this?
Well, the issue is, Dr. Jihad, we don't have a crystal ball. We don't know who's going to do good 20 years from now. We have prognostic factors, right? We kind of know you have a probability of doing good or bad, but I mean, do you want to gamble with that? I mean, hindsight's 2020. If you're on treatment and then 5 years later, 10 years later, we can tell you, oh, your disease is mild. Maybe now it's time to de-escalate. But in the beginning, we don't know. So I think, we should if available, we should, all the evidence shows if you hit hard early, you do better. Whether if you look at the Scandinavian countries or even the other trials, the head-to-head trials, teriflunomide versus ofatumumab, interferons versus ocrelizumab. People started on high efficacy treatments do better than the ones started on low efficacy treatments. So I think I would say, it would become more approachable to start aggressive early, and then we can go a couple years later, and then we can ask that question, was it worth it or not? But that's just my bias.
Yeah, I agree with you. Any comments? Anu, Basim? High efficacy from the beginning?
Yeah, just to answer the first part of the question about we don't fully understand neuroinflammation, neurodegeneration. Actually, our concept of the immunopathogenesis of MS has evolved significantly the last few years. And now we know that there are two parallel processes ongoing. There is a peripheral inflammation, which is mediated by the B cell and the T cell that I showed, that invade the central nervous system and produces active inflammation. And this correlates with gut-enhancing lesion, UT2 lesion, and acute relapses. And this is really predominant in the early stage of the disease. But at the same time, and in parallel, and from the beginning of the disease, there is an ongoing, what we call smoldering disease in the central nervous system, which is mediated by a compartmentalized inflammation in the CNS, driven by B cells in the germinal centers and the meninges, and by the microglia, which are the basis of the slowly expanding lesion that I showed, that are expanding slowly and eating up the brain. So these two processes are ongoing from the beginning. It's predominant in the peripheral neuroinflammation. As time goes by and the disease progresses, and with aging and neuroimmunosenescence, when our inflammatory processes decrease and our immune system decreases in intensity, we start having more predominance of this smoldering disease. And this is why we see more progression less GAD-enhancing lesion, less relapses. So our concept really has evolved, and we do understand now the neuroinflammation and neurodegeneration. Now, regarding they hit high, they hit strong early on. I understand the point, and I fully agree with what Ahmed said. There is still what we call benign MS. And we all agree that there are patients that we see 20 years later and are still doing extremely well on very minimal treatment like interferon. So there are those cases, but the problem is, like Ahmed said, there is no way to diagnose them prospectively. It's almost always a retrospective diagnosis, and you cannot take the chance of allowing all this inflammation, all this axonal loss, all the small disease to go on from the beginning, gambling that this patient ultimately might turn out to be benign. So this is the issue. We're not saying that there is no benign MS. I think it exists, but the diagnosis is always retrospective.
Yeah, thank you. We have two questions from Marwa Ahmed, one to Dr. Bassem and one to Dr. Ahmed. So, Dr. Bassem, what are the potential challenges or limitations in implementing 2024 diagnostic criteria in routine clinical practice, especially in resource limited setting? This is one part. And how might over-reliance on advanced MRI biomarkers, central venous sign, paramagnetic lesion, affect accessibility and equity in MS diagnostic globally?
Yeah, this is an
So this is
excellent
the question. Yeah.
Yes, so I want to emphasize that when we discuss these McDonald criteria and we added those new specific biomarker, highly specific for MS, the CVS and the Pearl, you have to remember that 80% of your MS cases are going to still be diagnosed with the 2017 criteria without using all this biomarker. Now, these 20% of cases where we're going to need those biomarkers are the difficult diagnostic cases. You know, the patient with migraine presenting with numbness or a visual aura and has multiple white matter lesion, or a patient above 50 presenting with a progressive weakness of the lower extremity and has multiple periventricular lesion and has hypertension. These are the difficult cases where we're going to have to rely on these CVS and Pearl, and they will be of great help because of their high specificity. Now, of course, we're going to need to train our neurologists, we're going to need to train our radiologists to know how to read them, but the actual sequences are very simple. Oh, and this was a previous question also that I read. All you need to detect those is a simple sequence, which is the SWI, which is a sequence we use routinely in our MS patients and MS MRI protocol, or the T2 star. Either one would do well and will be enough to diagnose these, even on a 1.5 Tesla, but of course, better on a 3 Tesla. And what I recommend all the neurologists here is to do exactly what I did in our center in Harley Street, which is basically asking your radiologist to make one extra sequence, which is a superimposed SWI over a flare. And this is very simple. He can do it in a minute, just superimpose two sequences. And then you can see the lesion, and within it, the central vein sign, or around it, the paramagnetic rim lesion. So this is my answer to the question. They will not be used in every case, but they will be extremely helpful in these very problematic diagnostic cases, and the sequences are not too advanced to perform.
Thank you. Dr. Ahmed, question to you from Marwa also. How do you balance the risk of side effects with the benefits of early high efficacy DMTs in newly diagnostic patients? So you have a new patient, how to start high efficacy DMT?
You know, it's a great
decide.
question. I mean, we could spend an hour just talking about this, but I
We
mean,
don't have
think,
hour.
yeah, we don't. I mean, it really goes down to physician-patient relationship. You know, our patients, they trust us. They trust that you are going to give the best care possible, and you're the most knowledgeable person that can deliver it. So there has to be that trust. But at the same time, you should be able to be knowledgeable to give these medications. So what do? If I feel someone is a highly active or rapidly evolving, I have given alemtuzumab. I've given more than 65 people alemtuzumab. Highly toxic, highly potent, excellent medicine, but it's got so much side effects. But here's the interesting thing. I was talking about safety and efficacy. As physicians, we like to go more for the safer side. Our patients are willing to take risks. And it's so interesting that if you look at my alemtuzumab group, I've had 2 people with thyroid resection from autoimmune thyroiditis. I've had 1 person with ITP who's had a splenectomy. I had 1 person who had a kidney biopsy because she had protein, but it was minimal change disease. It wasn't autoimmune nephropathy. But here's the crazy thing. If you ask any one of those people, would you do it again? It's unanimous. They would all do it again. No doubt. So it goes back down to I think we have to trust that our patients might be willing to take risks, but at the same time, you need to be able to deliver that risk to them. It's a hard question, but I mean, it goes down to physician-patient relationship. And
It's case by case, yeah.
that's how I approach it. I don't know.
If I can add one point to what Ahmed said, I fully agree. But at the same time, we have to remember that our new highly effective medication have a very good safety profile now. If we look at cladribine with almost 15 years follow-up and the immune reconstitution, within 1.5 years, you're back to a normal immune system, so without any risk. If we look at our B-cell depleting therapy, now we have almost 12 years of follow-up on our B-cell depleting therapy with excellent safety profile. Even the incidence of hypogammaglobulinemia is very low and does not correlate to infection. So keep in mind, we're not talking anymore about alemtuzumab or cyclophosphamide or mitoxantrone or natalizumab and JC virus positive. We're talking about new high efficacy medication that are relatively quite safe. So we keep that in mind. Beside what Ahmed said, that most patients will probably bet for efficacy rather than safety.
That's a great point. That high efficacy, the highly efficacious doesn't necessarily mean dangerous anymore.
Exactly.
They are safe, relatively.
Yeah, there was a
add
time
that-
we.
Can I
Sorry, go
just-
ahead.
Can I just add that, I mean, there are countries that are very conservative, like for example, UK. Even in such countries now, B-cell depletion is the first line. So you just have to have a diagnosis of MS, and then the medicine of adalimumab comes to the house. That's it. So then you go back and see the neurologist after a few months. So it's reached that stage now. So people are more comfortable with the use of these medications, especially when you have long-term follow-ups showing poor outcomes in people who have quite significant lesions to begin with.
There was a time we didn't have high efficacy except Tysabri and Gilenya. Now we have, as Bassem said, you have more drugs, so we have more options. We have another question here. What about time? We are 9:55 now. Now
I
53
think, Doctor, we should move to the clinical cases.
Okay, let's take one question only.
Yeah, sure.
And yeah, one question before we, because the panelists will be leaving. How is suboptimal response to therapy defined? What steps should you follow to identify? This will be the last question, I promise. Dr. Anu?
Yes, so suboptimal response, so there is the time factor to it. How long should you wait to say it's suboptimal? And what is the response you're looking for? So really in my practice, and as the guidelines would say in most of our practice, any new clinical relapse, unambiguous relapse, any new clear unambiguous inflammatory activity as a new lesion, which is either a gadolinium enhancing lesion or a new lesion or an enlarging T2 lesion, would be considered as a failure of the drug, provided adequate time has passed after starting it, and which kind of varies. For ocrelizumab, I would say probably it's 6 months, while for cladribine we have to give at least an year or more. So there is some variability there, but that is our cutoff. In situations when you're doubtful, for example, somebody already has a lot of vascular changes or migraine spots, and there are 2 new spots, 1 new spot, and you don't really know if it is MS related or not, then we recommend that you wait and see if more spots occur, at least 2 spots. So the criteria becomes stricter. Of course, new spinal cord spot would be unlikely in migraine, so that will be an indication to switch. So thresholds, in our opinion, are low because we have so many effective drugs. Especially if you're on a low efficacy drug, it is justified to switch to a higher efficacy drug. If you're a high efficacy drug, you may not have many options other than switching sideways.
Thank you very much. Great. So we have still more than 1,000 attendee, and we have 33 questions pending. So it's very
Wow.
difficult to understand, difficult to answer all of them. So I think we stop at this, and then we thank Dr. Bassem, thank Dr. Anu. You can stay with us if you want. And we go to Dr. Ahmed Shatila, clinical cases. Hopefully you can finish in 10 minutes, 10,
I
15
will.
minutes.
Yes. Thank you very much. Let
Yeah,
me
thank
share
you.
my screen.
Please.
And where is it? It is right here. There we go. We hide this. Sorry. Hide floating. Okay, sorry. It's towards the end. So now we're going to do case present. I had two ready, but for sake of time, I'm just going to go with one. Case number one. This is a 19-year-old female who presented to the neurology clinic for the first time back in 2021. On May 2021, she had numbness in her toes, reached her pelvis. Right was worse than the left. She wasn't given steroids, never had any neurologic symptom prior to that. No tingling, numbness, double vision, blurred vision, loss of vision, or anything lasting more than 24 hours. She did have a myelitis, and so she had a sensory level, which is bilateral lower extremity paresthesia. It's about one side worse than the left. When you look at the MRI at the time, she did have periventricular, she had subcortical, she had typical Dawson fingers, as you can see, and she had GAD-enhancing lesions, which is seen on the image on the right. So based on the 2017 McDonald criteria, she had two lesions in two different areas. That's the dissemination in space, and she had GAD-enhancing lesions, dissemination in time. Brain MRI showed multiple small defined T2 flare, as I said. Subcortical deep wipe matters. A couple juxtacortical. She had a couple enhancing lesions. So what did we do for her back in 2021? I gave her Kesimpta. She was given Kesimpta back in 2021. Now, Kesimpta is given every 4 weeks, but the first month you got to give 4 injections. Day 0, day 7, day 14, and day 28. You skip day 21. And after that, you're given every 4 weeks of subcutaneous 20 milligrams of ofatumumab. She was given it. First 2 doses gave her fever and chills, which is not uncommon. Panadol works wonders on that. After that, she did great. So what does her MRI look like? 6 months after rebaselining. So now this is a little bit backwards. The MRI on the right is the baseline MRI. The MRI on the left is the one 6 months later. What it showed is that there were some improvements. Some of the lesions completely regressed, and the ones that didn't regress, that some actually some disappeared, and some became smaller or less conspicuous. And there were no new lesions, and there were nothing else reported. So she was actually, currently I have around 73 patients that have received Kesimpta ofatumumab. And from my experience, 96% of the patients who get it have a stable MRI or improved MRI. 16% of them have an improved MRI. 80% have a stable MRI, and only 4% of the patients had a worsening MRI. And that was partly, most likely due to, that was the MRI that was done before baseline. But I don't have proof of that. So I usually tell them 96% of people getting ofatumumab will have a stable or improved MRI. I would go to case number 2, but for the sake of time, I will not go. This is one on cladribine, but this is for another presentation for another day. I will send it back to Dr. Jihad just for the sake of time, sir.
Okay, thank you very much, Dr. Ahmed, for finishing very fast. We are 10 o'clock exactly now. So we conclude by thanking the speakers. Number 1, Bassem, Ahmed, Anu, thanking Dr. Yasmin Mitwalli, Dr. Maya Zainuddin, and thank the IVPN in general, the organizer, National MS Society, and all the participants. And for the participants, you'll get your certificate within 1 week on your email. And if you want to chat, you can go to the IVPN, Neuropsychiatry, website. You'll find the recording and you'll find any communication with them. And with this, we thank the society, thank the consortium of OMS and the Ministry of Health and Health Prevention for the accreditation. We thank you all and wish you good night.
Thank you, Dr. Jihad. Allow me to thank you for an amazing moderation. I always learn from you how to moderate a webinar. Really, thank you so much.
Thank you very much, Dr. Meg.
Thank you for accepting our invitation. Let me also thank our great speaker. So Dr. Shatila has been with us since years. He do webinars with us. Similarly, Dr. Yamut, Dr. Jacob, thank you for accepting our invitation, and hopefully we'll have more collaboration in the future with us, and also in collaboration with the National MS Society. Finally, I would like to thank our sponsor, because without their support, this webinar could not have been done. So thank you, Yasmin Mutwalli, for all your efforts and in making this webinar successful, and for the National MS Society for sponsoring such educational events in our region, so we can all elevate or optimize the care of our MS patients. And also allow me please to thank our endorsing body, the Consortium of Multiple Sclerosis, for their trust. So thank you. And the big thank you goes definitely, as Dr. Jihad, I join him to thank our 1,000 attendees who attended our webinar until the end. And as Dr. Jihad mentioned, you will receive all your certificate, your CME accredited certificate of attendance by email within 1 week of today. And you can always revisit this webinar by visiting our IVPN library on our website, where you can access the recording link of this webinar to revisit the lecture. This is the website for our IVPN library. Also, follow us on social media platform for more educational webinar about multiple sclerosis and other neurologic disease. And on the final slide, you will see the QR code for the link for all the National MS Society activity. I don't know if you have anything to say, Dr. Yasmin, before we close this webinar.
Thank you. Thank you so much, Maya, for this great webinar. Thank you to all of our incredible speakers, Dr. Shatila, Dr. Anu, Dr. Basim, and Dr. Jihad for the incredible moderation. Yeah, please, for everyone on the webinar, if you could scan this QR code, it would take you to the NMSS website, where you could find a lot of resources that are for patients, so that you could share them with your patients. But there are also other resources for a few initiatives like the research grant, the fellowship, and a lot of other programs that we do. So yeah.
I echo Yasmin, just to remind all the neurologists or neurology experts in the UAE who are interested in like a clinic research fellowship to apply. So we have a joint program with Menactrims and the National MS Society, a research fellowship program. So visit their website or our website as well for all the details. And I really encourage you to take the opportunity and apply. And also Dr. Shatila, Dr. Jihad, and Dr. Anu, if you have colleagues or any team of your team member who are interested in this fellowship, please encourage them to apply. So have a good night, everyone. I think now we can close this very successful webinar. Have a good night, everyone, and see you all very soon.
Good
Good
night.
night. Thank you all. Good night.
Salam, everyone. It was great. Thank you.
مع السلامة. أحلاما سعيدة.
Bye bye.
Bye bye.
Bye.
Bye-bye.